Okay, I think in this day and age, the problem that women have, or rather modern couples have, is that they usually start too late in planning for a family. We would normally advise women to start trying for a family maybe from their mid to late 20s. But I think in this day and age, career women will only start looking at families from about late 30s, mid 30s onwards. So that is the main issue. Age and the natural decline in fertility with age is what most women face. Besides age, I think in general women who have problems with very painful menses, with very heavy menses, those who experience very abdominal distension and all that, those women should also perhaps consult their gynaes early, because these symptoms may point to underlying problems like fibroids or endometriosis, which can have a significant impact on fertility, even if they're in their early 30s. A lot of women brush this aside because they think that since everybody has menstrual pain, everybody has clots during menses, that's normal, and therefore I should be okay as well. But a lot of them don't realize that if there are underlying problems like endometriosis, and by allowing this disease to progress, they actually significantly reduce their fertility potential by the time they seek treatment. Over the age of 40, if they manage to conceive, there are certain issues that we have to look at. In the first trimester, that means the first 3 months, they do experience a higher risk of miscarriage, because a lot of these embryos may not be very healthy as a result of maternal age. It's been shown by studies that there are higher risks of problems like chromosomal or DNA problems in the embryo. So if they do make it past the first trimester, then there are other issues like Down syndrome, or even for the mother, things like high blood pressure and diabetes during pregnancy. So again, it has to be very individualized and very tailored to the individual, the lady's health condition and their medical problems. And what a lot of couples don't realize is nowadays men have a big problem as well. A lot of them, in fact, about 1/3 to 2/3 of couples who have problems conceiving, the man plays a significant part in the problems they face. A lot of them are in a state of denial. They refuse to accept that they have a problem because they smoke, and they say, since my friends smoke and they have kids, I should be okay. So my wife should be the one seeking treatment and going for checkups and all that. Actually, a very simple sperm test would tell us if he is okay or not. And if not, there are various ways that we can help to overcome this problem so as to improve their fertility potential. Because the infertile couple, you think of it as a balance between the husband and the wife. It's a scale. We try and improve the wife's fertility potential, but if the husband has a problem, then we should try and improve that as well, so that overall the chances of getting pregnant actually improves. A lot of husbands refuse to come, and therefore the wives, actually having done everything else, are actually left in a state of dilemma because they don't know what else they can do. So if all that is done and all the tests are done, then treatment can be instituted depending on what we find. For example, endometriosis and all that can be medically treated, or some of the conditions can be treated with surgery. The husbands can undergo medical treatment, usually in the form of oral medication to try and improve the sperm. And if all that doesn't work, then we can actually help the wives to track their ovulation by giving them medication, doing scans, and actually pinpointing down to even the very hour that ovulation is going to take place. So we can tell the husbands, okay, on this day you don't play golf, please come home early and try. And because the fertile window is a very narrow 24 hours, that's the best time, and we can pinpoint to them which 24 hours they can try. So golf can come on other days of the week. And by trying that, by doing things like artificial insemination or IUI, you are improving the odds by putting the sperm further in so that they then reach the egg in a shorter distance that they have to swim. And if all that fails, then of course the last treatment of choice is to do IVF, which is test tube babies. There is still a lot of stigma, a lot of resistance among couples to this mode of treatment. But more and more, I think women are turning to this as an earlier option because they realize that IVF gives them the best chance of success. And this is especially so in couples who are, or at least if the wives are already in their late 30s or early 40s. That might be the first form of treatment that you should consider. So, in a nutshell, start treatment early, and then if you've been trying, even if you're young, if you've been trying for about a year or so with unprotected intercourse and nothing happens, then perhaps you should consider getting treatment early. Any form of medical treatment comes with certain risks, certain side effects. Surgery, of course, we all know there are risks to things like infection, bleeding, and certain specific complications depending on the kind of surgery you do. For example, those keyhole laparoscopic surgery, there are certain risks to like injuries of the gut, the bladder, and the other organs. But all these can be kept to a minimum if you seek treatment when the condition is still in its early stages, and by getting treatment from experienced surgeons, you can actually minimize the side effects. IVF in particular, the main side effect is actually when you overreact to the injections, because in IVF you actually go through a series of injections to try and get your eggs, the ovaries, to produce more eggs. Sometimes when you overreact and produce too many eggs, a lot of women will experience bloating, tummy distension, and there's actually a lot of fluid accumulating in the tummy, something called ovarian hyperstimulation syndrome. That condition can be controlled quite easily with certain modern medications or in certain modern techniques where we actually retrieve the eggs but do not replace the eggs immediately. We actually freeze the eggs, the embryos, and allow this condition to settle. And we do something called a frozen embryo transfer about 2 or 3 months later. That will significantly reduce the chance of this ovarian hyperstimulation syndrome.